About the present, as you know, I mentioned there are 5 FDA-approved grafts: Anurex, Excluder, Zenith, PowerLink, and Talent, shown here. But there are really 21 endografts that have been used in man at least once. The ones in white here are those that are on the horizon, have been used and then dropped for various reasons, or are in preparation for being introduced, presently being used in Europe, but being introduced in the US. The ones in yellow here are the ones that I've already mentioned that are FDA approved, and some of the lighter connoted grafts are ones that have either fallen by the wayside or are being used in Europe, but are not on the horizon in the United States. So the last one I will mention subsequently are new concept grafts, the Trivascular and the Nelix, and I'll come back and mention those. Now, the promise of EVAR is that it would reduce operative mortality and morbidity, and it in fact has done that. There's no question. Shorter length of stay, more patients are candidates for repair because they were inoperable by open techniques, and there's clearly been multi-specialty involvement. The one area where it hasn't lived up to its promise yet is reduced costs, but with better systems, and I'll talk about this later, of follow-up, even reduced costs, I think, are on the horizon soon. You all know about the EVAR and the DREAM trial, and more recently there's been the ATOM trial, which has confirmed that open repair has a higher mortality than endovascular repair, and that's consistent across all randomized studies. So I think that's accepted. And in answer to the question, should EVAR be offered to every AAA patient needing repair regardless of age or risk status? In the old days, we said good risk patients should get open repair. We don't say that anymore. The answer is yes. All patients with good anatomy or favorable anatomy for EVAR, in my opinion, should be offered EVAR, and it's what I would choose for myself if I had to have an aneurysm fixed. So this acceptance of EVAR, which is now pretty general, is reflected by the rising percentage of EVAR cases and the falling percentage of open cases done around the world. So EVAR technologies, needs that are now largely met. 60 to 80% of AAAs are treated by EVAR. With the newer third-generation devices that are improved and improving, made easier to use, I think the percentages of cases that can be done by EVAR, of AAA cases can be done by EVAR, is increasing. And still we have anatomy as a limiting factor, with both the iliac anatomy and the aortic neck anatomy being the problems. Evolving technologies and techniques are solving this and increasing applicability, which in my opinion will get up to the 80 to 85% range soon. Some of these techniques are the conduits to bypass iliacs, branched and fenestrated grafts, which I think others are talking about. I'm not going to say much about, but it allows aneurysm repair to be conducted even if the visceral and hypogastric arteries are involved, and these branches can be revascularized, and that will increase as time goes on in the US. We're able to treat larger aortic neck sizes because the technology is improving, and we're seeing more flexible grafts. All these are here and now, and they will be spread more widely as time goes on in the United States. And these are just 2 examples, the Orfix and the Endurant, here shown as an Endurant graft, of more flexible grafts which are being introduced as time goes on, Endurant by Medtronic and Orfix by Lombard. We also have chimney techniques which are proving to be effective in certain circumstances. We have staple devices for better fixation. In situ fenestration is on the horizon, and I think we'll see techniques appearing that do that effectively. And of course, we're seeing more lower profile devices, so that applicability of EVAR will increase, and I would guess in subsequent years it'll be over 90%. This is an example of some chimney grafts from Malmo, Sweden, showing revascularization of visceral vessels. And here's the Aptus device with the accompanying staple, which can be used effectively and has been used effectively in clinical trials. Even with ruptured aneurysms, technology is allowing more of them to be done. That was the original title I was supposed to talk on, but it is still controversial. It's my belief that EVAR is definitely a better way if the anatomy is stable, and it was proven in recent collection of the world experience which we carried out, showing that in comparable cases, EVAR mortality is dramatically less than open repair mortality. And I think that nails it, although in Europe there's still randomized trials which some other people are conducting. I don't happen to agree with them, but they're doing them anyhow. And in ruptured aneurysm settings, 60 to over 80% of cases, I believe, will be treatable by EVAR, with only a small percentage, around 20%, requiring open repair. Other unmet needs, there really aren't too many, and I don't believe, in my opinion, they're very pressing. A lot of companies are talking about lower profile devices. I think it's nice. Lower profile is great. It allows more cardiologists to get into the game, but with the current techniques for percutaneous introduction, even with large sheaths, I don't think that lower profile is as big a deal as some people have talked about. And then there are the newer concept devices. You all know about the trivascular graft, which was dropped for a while, is now coming back. It's a polymer-supported stenting system, fixation system, and it allows a lower profile device. And then there's a really new concept, the Nelix device, which is a sac-filling device with stent-defined flow lumens. I don't have time to go into the details, but there are these polymer-filled endobags which fill up the interstice, or the sac lumen, and the flow is maintained through these stents inside these polymer-filled endobags. And that's the Nelix device, which is in clinical trials both in Europe and the United States. So future perspectives, where will we be in 2020? I think that many of the techniques I've mentioned will be perfected and more widely adopted. EVAR will probably be applicable to over 90% of aneurysms needing treatment. Not 100%, but probably over 90%. There'll still be a spot for open repair. So it's clear that over the last 20 years, EVAR has changed the world, and I've been lucky enough to be part of that for most of those 20 years. Thank you very much for your attention.